This is a disease, as I said earlier, that we need to own, that we need to be most expert at. There are many areas of emergency medicine where our consultants, maybe not in the ED, but overall have more knowledge. This, the acute treatment of anaphylaxis, we should know better than anyone in any specialty. Number one, we do not always know how to diagnose anaphylaxis. This is the diagnosis, and I want to focus on what's down here. There are 5 causes, 5 steps, 5 reasons for everything. That's not really true, but I say that a lot, and after a while I've begun to believe it. These are the 5 systems for evaluation of anaphylaxis, and anaphylaxis is a systemic reaction involving 2 or more organ systems as defined by the American Association of Allergy and Immunology. Skin, like erythema, mucous membranes, swollen lips, uvula, respiratory, wheezing, cardiovascular, vasodilatation and tachycardia, and GI, which is often misdiagnosed, especially in the little Twizzlers where they think it's food allergy or reflux. If you have someone who has wheals, is urticaric, and that's a new word, and has vomited, that's anaphylaxis. 90% of people have skin or mucous membrane involvement, 10% don't. If you do know someone has an allergy to peanuts, and they say, I just ate peanuts, and they become suddenly hypotensive or suddenly begin to wheeze, then it's just one. But in general, 2 or more organ systems. Number 2, the number 1 cause of death in anaphylaxis is the failure of the patient, family, EMS, nurse, or physician extender to give epinephrine in a timely manner. In fact, less than 1/4 of cardiac arrest due to anaphylaxis got epi before the arrest. We need to recognize it and treat it. VFib, shock, anaphylaxis, epi. The dose of epi is 0.3 IM. In superhuman-sized people, you can go as high as 0.5. As people get smaller, use a percentage of 0.3. The EpiPen is 0.15. You don't have to be exact. 0.3 IM. The thigh is better than the deltoid, but I'll tell you, on an airplane or in a public place, when you're dropping somebody's pants or pulling up a skirt, and you go, but I'm a doctor, it's okay to do the deltoid. Be facile with the 5 therapies of anaphylaxis, but anaphylaxis epi. If the only thing you do in VFib is shock, patient will survive. If the only thing you do in anaphylaxis is give epi, you're going to get outstanding results. You can supplement it with H1 and H2 blockers, steroids, and tank them up. The thing we do the least, even as experts, if we do give epi, is not volume bolus, a minimum of 20 cc's per kilo, 1.5 liters. Benadryl is not an effective therapy. There are no controlled studies, not one, to show that Benadryl, diphenhydramine is the other brand, diphenhydramine or the brand name Benadryl, there's no study to ever show that it works in anaphylaxis. It takes 40 minutes, it's an adjunct, it is an antihistamine. Anaphylaxis, epi. Being old should give you privilege, you should not take away privileges. As you get older, you should be able to get into the movie theater cheaper. You should get a better seat on Southwest. And most importantly, you should have the right to live with anaphylaxis. If someone is older, give them epi. And in a study I showed earlier, epinephrine is safe in older people. It is very safe. Yet in 2/3 of patients over the age of 50 in this well-done study out of British Columbia, they did not receive epi. Anaphylaxis, epi, 0.3 IM. Now I want to talk about IV versus IM. If your patient is dead, use IV medicine. If you'd like to make your patient dead, use IV medicine. And what I mean by that is, if they ain't dead, don't give it IV unless you want to try to kill them. And I'm talking mini push here. 1/10 of a cardiac AMPA epi seems like a really small amount. It's 100 mics. The normal dose of epinephrine is 1 to 2 mics a minute. Do not use mini push epi. If I cursed, which I never do, I'd say mini push epi ain't worth dick, because you are going to kill somebody with it, or at least give them a heart attack. That's where the complications are with mini push epi. This animation doesn't work, so I'm going to talk about it. The single bestest way to do epi in anaphylaxis is as follows. Remember that we are mortal, and we cannot, I've been using that clock, and we cannot do calculations. Put 1 milligram of epi in 1 amp, put 1 amp or 1 milligram of epi in 1 liter of saline. Just inject it in here and piggyback that into a high-flow IV so that you're dripping the epi in slowly into a fast-flow IV. Then you can just titrate it. You need to know how to use the EpiPen. Up to 9 out of 10 people use it wrong. They inject it in their finger, etc. They don't hold it right. They shoot it in the air, blue sky up. And this is an embarrassment to me, and I had to learn how to use it too. Only 1/4 of us know how to use the EpiPen and teach it correctly. Be sure your patient can obtain the EpiPen as my final fact. Only about half fill it within a year. Who knows the price of the EpiPen? It's any one of those. And if you have $10 in your wallet, you try buying it for $730. So I want to say one more important thing. Write, not EpiPen or generic EpiPen, that's still expensive. Write generic epinephrine auto-injector, and then based on their insurance or lack thereof, they will get something. And they may get the Adrenaclick, or what it used to be called. Generic EpiPen is still a branded EpiPen. It's just the generic version of it. Our job is to secure the ABCs, airway, breathing, cardiovascular stability, every time, every patient. Anaphylaxis, epi. Thank you.